The IRRAflow cranial access bolt is a single-lumen cranial access device designed for use with the IRRAflow dual-lumen catheter. It is indicated when ICP monitoring is required and for externally draining intracranial fluid as a means of reducing ICP in patients where an external drainage monitoring system is needed. The use of the bolt is at the discretion of the healthcare professional to secure the catheter to the patient's skull while providing a sealed connection that prevents unintentional fluid leakage or entry. When applying the device, the patient should be positioned supine with neutral head alignment. Prepare the surgical site in standard sterile fashion per facility preference, whether placement is to occur in the OR or in the ICU at the bedside. Maintaining strict sterile technique throughout the procedure is critical to minimize the risk of infection. Prepare the hand drill by loading the IRRAflow center point drill bit and tightening. Then set aside. Ensure that you are using only the sterile drill bit provided with the kit and the specified IRRAflow catheter to maintain proper function and sealing. Referencing the pre-procedure imaging, mark the location of entry. Typically, this is Coker's point, which is found approximately 10 centimeters back from the nasien and 2.5 to 3 centimeters lateral to the midline. This usually corresponds to the mid-pupillary line. Alternatively, one can feel for the coronal suture and mark a spot 1 centimeter anterior on the mid-pupillary line. Adjust the bed elevation so access is comfortable and the patient can be held securely by nursing staff. Once the markings for the entry point have been created, visualize 2 anatomical reference points on the patient to plan your trajectory. The first is the ipsilateral medial canthus, and the second point is 1 centimeter in front of the tragus. These anatomical landmarks serve as a reminder of the correct trajectory for drilling and subsequent catheter placement. As you prepare for drilling, orient the drill along the intended trajectory and have an assistant stabilize the head under the sterile drapes to minimize head movement. Create a skin incision and then scrape the periosteum off the skull. This scraping may prevent the drill bit from skiving and ensures clear visualization of the entry point. The pre-procedure imaging will indicate if there is midline shift or any other anomalies that may require modification of the trajectory. Remember, just a couple of degrees of variation in angle at insertion will result in significant translation of the catheter's tip position at target depth. The medial lateral trajectory angle is straightforward to monitor because you can usually see the patient's nose during insertion. However, the posterior angle can be more difficult to judge. Some prefer to have an assistant standing to their side who can evaluate if the proper anterior-posterior angle is being followed. Hold the drill at a 90-degree angle orthogonal to the skull and with gentle pressure, drill a burr hole. Stay tuned to feedback as you proceed through the outer surface and into the cancellous bone. You will likely receive feedback once you reach the inner table. Apply slow, gentle pressure once you reach this layer. Practice care to pierce this bone layer without plunging into the brain. Once the skull is opened, the dura is often still intact. Irrigate this area copiously to ensure there are no bone shards or debris and minimize the potential infection risk from introducing any foreign materials into the brain. Once complete, proceed to pierce the dura with the provided dura opener. One useful tip is to use a pair of scissors to spread the leaflets of the dura. Obtain the bolt and insert into the twist drill hole. The trajectory should be toward the ipsilateral medial canthus and the bolt should be perpendicular to the skull. Ensure that the trajectory of the insertion of the bolt is the same as the intended trajectory of the ventricular catheter. Rotate the bolt clockwise to secure it into the skull. Each full rotation advances the bolt by 1 millimeter. Continue rotating until the threads are fully engaged and they are no longer visible below the skin, or until the bolt is securely fixed, whichever occurs first. Note that the bolt is pre-assembled with the cap loosened to allow catheter insertion. If the dura is not adequately punctured, the dura opener may be inserted through the bolt to pierce the dura. Once you are prepared to pass the catheter, insert the stylet into the drainage lumen and advance the assembly into the bolt, positioning the catheter at the desired intracranial location. To ensure appropriate depth, note the following measurements. The catheter has 1 centimeter demarcation starting at the tip of the device up to 15 centimeters. The bolt is approximately 5 centimeters in length. Therefore, if the ventricular location is 6 centimeters from the inner table, the number 11 should be visible at the cap. This allows 5 centimeters of the bolt body plus another 6 centimeters of the catheter extending beyond the end of the bolt. Once at the desired location, hold the position of the catheter steady above the cap and remove the stylet to confirm CSF flow through the drainage lumen. Cap the drainage line and position the stopcock on the irrigation line if needed. Make sure to hold the catheter's position and secure the bolt cap at all times. If the 11 mark at the top of the bolt cap is visible, rotate clockwise relative to the bolt until it is fully tightened as far as possible. You cannot over-tighten the bolt cap. Verify that the bolt's black band is visible only through the cap's viewing window. This confirms the cap is fully seated. Now you are ready to connect the IRRAflow cassette to the catheter and begin active fluid exchange therapy. If the initial trajectory is unsuccessful, the catheter then bolt method may be utilized. First, insert the catheter freehand to the desired location. Then slide the bolt down the catheter shaft into the drill hole and secure it by rotating clockwise until fully engaged. Once secure, check for CSF flow. Care must be taken to not inadvertently advance the catheter beyond the intended depth during this maneuver. A nurse or sterile assistant can hand over the intelligent cassette tubing and assist with the connection before beginning active fluid exchange.